Okay, girl, come here. Let's make this make sense. Today we're talking about congestive heart failure. And if CHF has ever confused you, I want you to forget about all the complicated terminology for a minute. Think of your heart as a pump. Your heart's job is to take blood and pump it forward throughout the body. When the pump can't keep up with what the body needs, we call that heart failure. Now here's where I want you to understand something. Heart failure does not mean that the heart has completely stopped working. The heart's still beating. The problem is that it can't pump effectively enough to keep up with what the body needs, and pressures start building up. When blood isn't moving forward efficiently, it starts backing up. That's the key to understanding congestive heart failure. Remember that. Now let me show you why this matters. Left-sided heart failure. Think about where blood backs up when the left side of the heart's struggling. Behind the left side are the lungs. So if blood starts backing up towards the lungs, fluid can build up there. And what is your patient going to tell you? I can't breathe. They may be short of breath. They may have crackles. Their oxygen saturation may be decreased. They may have a cough. They may tell you, I can't sleep lying flat at night. I need to sleep in my recliner, or I have to have 3 pillows propped up behind me. This is called orthopnea. Or they may tell you, I fall asleep and I wake up gasping for air. So when you're trying to remember left-sided heart failure, I want you to remember left equals lungs. Left side fails, blood backs up towards the lungs, the patient gets pulmonary congestion, which in turn makes it difficult for them to breathe. Now let's discuss the right side. Right-sided heart failure. If the right side isn't moving blood forward effectively, where does that blood back up? Into the body. So now we're looking for systemic venous congestion. You may see swollen legs and ankles in your patient, peripheral edema, weight gain from fluid, jugular venous distension, or also known as JVD, sometimes abdominal swelling or ascites. So remember, right equals the rest of the body. Left backs up into the lungs, right backs up into the body. That's your foundation. Now let's say your CHF patient arrives to the hospital, short of breath, with bilateral lower or both legs swollen. What are we watching? First, we're watching for breathing. How does the patient look? Are they working hard to breathe? What is their respiratory rate? What is their saturation, their oxygen saturation? What do their lungs sound like? Do you hear crackles? Have they gained weight? Do they have a history of heart failure? What medications are they taking? If we hear crackles, this is suggesting pulmonary congestion. Now let's look at fluid status. Look at their legs. You see the edema? How much? Is their abdomen distended? Do they have JVD? What is their weight? And this is why daily weights are so important in our heart failure patients, because fluid has weight. So if your patient gains several pounds very quickly, we know this is not fat. Fluid equals weight. Think fluid. This is also why we care about strict input and output. How much fluid's going in and how much is coming out. If we're giving a diuretic, we want to know, is the patient diuresing? Are they making urine? Is the congestion improving? Are they breathing better? Is their edema improving? Is their weight coming down? But while we're getting that fluid off, there's something else we have to watch. The kidneys. Why? Because the heart and the kidneys are closely connected. So what are we watching? BUN and creatinine. We're watching their renal function, and we're watching electrolytes, especially potassium. Why? Because many of these patients are receiving diuretics, and depending on the diuretic, electrolyte levels can change. And potassium abnormalities matter. Why? Because potassium affects the heart. We're not just saying, oh, potassium is a lab. We're asking, why am I watching it in this patient? This is how I want you to start thinking clinically. Now let's talk about diagnostics. If we suspect heart failure, one blood test you may see is the BNP or NT-proBNP. Here's the simple version. When the heart's under increased pressure and stretch, it releases natriuretic peptides. So an elevated BNP or NT-proBNP can support the diagnosis of heart failure in the right clinical situation. But don't look at one lab in isolation. We're looking at the whole patient. Symptoms, physical assessment, labs, imaging, history, everything all together. Next, we're going to talk about the chest x-ray. Signs of pulmonary congestion is what we're looking for. Fluid in the lungs. Sometimes we'll see an enlarged heart on the chest x-ray. Then we're probably getting an EKG. The EKG is not going to simply flash and tell us, congratulations, your patient has congestive heart failure. That's not its job. We're looking for clues about what's happening with the patient's heart. What is their rhythm? Is the patient in AFib? Is there evidence suggesting previous or current ischemia? Are there conduction abnormalities? What may have contributed to this patient's heart failure or their current decompensation? And then we have one of our big tests. We've all seen it, the echocardiogram. And echo lets us look at the structure and function of the heart. How are those chambers functioning? How are the valves? And what is the ejection fraction? Now, don't let ejection fraction intimidate you. Think about it like this. The left ventricle fills with blood and then it squeezes. Ejection fraction is basically telling us what percentage of the blood gets pushed out with each contraction. And here's another important point. A patient can have heart failure even when their ejection fraction is preserved. So we have different categories of heart failure. HFrEF means heart failure with reduced ejection fraction. That's commonly what people mean when they think about a weak squeeze. HFpEF means heart failure with a preserved ejection fraction. The percentage being ejected can look relatively normal, but the ventricle may be stiff and have difficulty relaxing and filling normally. So HFrEF, think squeeze problems. HFpEF, think filling and relaxation problems. Both patients can have heart failure, both can become congested, both can be short of breath. Now, what are we doing for these patients? Treatment depends on the type of heart failure and a patient's clinical presentation. But if we're talking about a patient who's acutely fluid overloaded, you're definitely going to see some diuretics. For example, a loop diuretic such as furosemide or Lasix. Why? We're trying to get all that excess sodium and water out of the patient. And what happens when we successfully remove that fluid? You're going to see less congestion, less edema in the patient, less pressure backing up towards the lungs, and hopefully your patient can breathe better. But don't just give Lasix and walk away. What are we monitoring? We're watching the patient's blood pressure, urine output, renal function, electrolytes, daily weight, symptoms, and overall fluid status. Because medications have consequences, and our job is to monitor and watch for the response. For chronic heart failure, especially heart failure with a reduced ejection fraction, there's also medications that improve outcomes over time. You may hear the term guideline-directed medical therapy or GDMT. For HFrEF, think about the major medication groups such as ARNIs, or sometimes ACE inhibitors or ARBs, depending on the patient, evidence-based beta blockers, SGLT2 inhibitors. These medications aren't all doing exactly the same thing. And that's going to be its own video because I want you to understand why we're giving each one instead of just memorizing a list of medication. Now, here's another important question. Why did this patient suddenly get worse? Maybe they stopped taking their medications. Maybe they've been consuming too much sodium. Maybe they're retaining fluid. Maybe their blood pressure is poorly controlled. Maybe they've developed an arrhythmia. Maybe there's ischemia, an infection. Maybe their kidney function has changed. So don't stop at just thinking my patient has heart failure. That's it. I want you to ask, why are they decompensated today? That's where clinical thinking starts. Now let's put everything together. Your CHF patient comes in and says, I can't breathe, especially when I lie down. You look at their legs, you see edema, you listen to their lungs, you hear crackles, their weight is up, maybe their BNP is elevated, and their chest X-ray shows pulmonary congestion. Their echo gives us information about the cardiac structure, function, and ejection fraction. Now let's connect everything. The heart isn't handling circulation effectively, pressure builds up, fluid backs up, the patient becomes congested. So this is how you're going to remember heart failure. Heart failure equals the pump can't keep up. Left equals lungs, right equals rest of body, suddenly weight gain occurs, think fluid, crackles plus orthopnea plus difficulty in breathing, think pulmonary congestion, edema plus JVD plus abdominal congestion, think systemic congestion, BNP, NT-proBNP, think heart stretch and pressure. Echo, think structure, function, and ejection fraction. Diuretics, think get that extra fluid out and monitor the patient's response. And that is congestive heart failure in simple terms. If this explanation finally made CHF click for you, follow me. And that's exactly how we're learning on this page. Not just memorizing 47 random facts without understanding what they mean. We're gonna start